Welcome, everybody, and thank you for joining us for today's webinar. My name is Archana Castellino. I'm the National Director of the Dystonia Medical Research Foundation Canada, and I'm thrilled to introduce our Supporting Dystonia Patients During the COVID-19 Pandemic webinar series today that we're hosting in partnership with Allergan and Abbvie Company. And I'm joined today by my colleague, Stephanie Inns, whom you very well know. And Stephanie and I are thrilled to have you with us today. For the benefit of those joining us for the first time today, I'd like to give you a short overview of our organization. The DMR of Canada was founded in 1976 by Sam and Fran Belsberg after their daughter Sherry was diagnosed. There was very little known back then. Our mission focuses on three areas. That's advancing research, raising awareness of the disorder, and supporting the needs and well-being of affected individuals and their families. Thanks to the community and our supporters, together we've come a long way in these three areas. Just a little housekeeping before we get started. First, a very important reminder that this is a webinar presentation that aims to provide dystonia patients and caregivers with information for support during the COVID-19 pandemic. We urge you to speak with your doctor or neurologist for a complete examination and to remember that you are in control of your health. A recording of this presentation will be made available and emailed to everyone once it's available online. Regarding questions, as you know, we've collected your thoughts in advance and we've shared that with Dr. Grimes to help him with the development of this presentation. As well, we will ensure we have lots of time for Dr. Grimes to answer the most frequently asked questions. So if you do have questions during the presentation, please feel free to type that in the Q&A section, which you should see at the bottom of your screen. My colleague Stephanie will be monitoring these questions throughout the presentation and will bring these questions to Dr. Grimes' attention at the appropriate time. There's also a chat function. Please feel free to use that to say hi to the others who are joining us today and to introduce yourself. But a reminder that we will not be monitoring the chat box for questions. COVID-19 has changed all of our lives significantly. We at DMRF Canada understand that its impact on the dystonia community have been substantial. And given our mission, we wanted to determine what we could do to continue to meet the needs of the community in the midst of the pandemic. Last fall, we conducted a survey to understand how COVID-19 impacted the lives and overall well-being of people living with dystonia. This survey ran for a few weeks, and many of the questions focused on how people were impacted by the pandemic, dating back to March 2020. The high-level findings of these are as follows. 82% described that their mental health was good to excellent prior to the pandemic. However, that changed after the pandemic was declared in March 2020. 63% reported stress and mental health challenges, and 28% reported that their ability to be physically active was affected. Overall, 50% of respondents reported a negative impact on their health and well-being because of COVID-19. In addition to physical and mental well-being, the pandemic has impacted access to healthcare and treatments. The survey results helped highlight the need for tools to help with self-management of dystonia and tools to improve mental health during this time. This webinar has been developed to help you live your best life with dystonia, even during COVID-19. Well, a lot has now changed since the survey took place, and we continue to face the challenges of the pandemic. So we wanted to check in with you again today by using a poll feature. I will now bring up a series of 4 questions to which you can share your answers. Please note that these questions these answers are submitted to us anonymously, and we will review them after you've submitted your answers. So I will now share that. Oh, apologies. You will now see a series of 4 questions. Okay, thank you very much, everyone, for sharing your answers. I will now share the results. Okay. So our first question was how important it is for you to maintain your injection schedule. And we have about 72% who said that it is very important for them. And before COVID-19, did you regularly experience any delays? It's good to see that 84% replied no, that they did not experience any delays, and there may have been a few delays otherwise. And post-pandemic, again, that is interesting that we see about 72% did not experience a delay. However, we see that 19% have responded that they've experienced a delay of over 6 weeks. That's an interesting point there. And the impact of these delays, we see many have reported no impact, which might be because of no experience in delays. However, those who have experienced delays, it might be moderate to mild. Right. Thank you very much, everyone, for sharing your input with us. Your input is important and helps us to continue to provide the community with the best support. And I'm sure this information will be useful for Dr. Grimes as he presents on our topic today. I will now turn things over to Stephanie to introduce Dr. Grimes.
Thanks, Archana, and hi, everyone. So today we're very pleased to be presenting our second webinar in the series, Pain Management for and it's my pleasure to introduce Dr. Grimes. So just wanted to give you a little bit of background of what Dr. Grimes has been doing. Dr. Grimes is the director of the Parkinson's Disease and Movement Disorder Clinic at the Ottawa Hospital. He's the head of the Division of Neurology and a professor of medicine at the University of Ottawa. Dr. Grimes received his doctorate in medicine and completed his residency in neurology at the University of Ottawa, and he spent 2 years at the Toronto Hospital and the Centre for Research in Neurodegenerative Diseases as a research fellow, specifically in movement disorders and molecular genetics. Dr. Grimes' major clinical interests are in the diagnosis and treatment of a wide variety of movement disorders, with an emphasis on Parkinson's disease and dystonia. He conducts clinical trials in Parkinson's disease and dystonia, exploring novel treatment options, and has extensive experience with botulinum toxin injections for the treatment of focal dystonia and hemifacial spasm. We're very pleased to introduce Dr. Grimes, and without further ado, I will hand it over to you, Dr. Grimes.
Thank you. Welcome, everyone. Thank you for asking me to speak. I was interested to see the picture where I look much younger and have less gray hair. So you'll see on the real video that that's not quite the case, but I'll take the younger picture. So I guess a few things. Let me just get my screen sharing here. So does that look right to people?
Yes,
I can see that.
Okay. So with most talks do need to have any disclosures. And so I have a few different disclosures. There's a couple of new pharma companies that are trying to launch some Parkinson drugs and have been looking for some advice that I've worked with, and also have done some consulting work and speaking with Allergan with regards to COVID and the pandemic and how it's affecting how we are able to provide botulinum toxin injections. As you heard, I am involved in doing clinical trials, and we do both investigator-led trials as well as those sponsored by industry, as well as private and public funding agencies to support our research work. Let me just, sorry, need to get my view changed here a little bit. I've lost all of you, but that's okay. So a few objectives I wanted to cover over the next 25 to 30 minutes was really take a step backwards and just talk a little bit about what our current definition of what dystonia is, a little brief of where we are with our understanding of dystonia, talk a little bit about pain and pain mechanisms and why we have it and why it's important, and then talk a little bit about where we are with how dystonia pain can be treated specifically. So dystonia is one of those very confusing terms in medicine. So it's a descriptor, meaning we use dystonia to describe a very specific type of abnormal movement, kind of like we use the term tremor or tics or myoclonus. And so it's a descriptor of a symptom, but we also use the term as a diagnosis. And I think this creates a lot of confusion in people's minds. It also, although we mostly think of dystonia as being a motor problem, but we now realize that there's certainly a significant non-motor component to people who have dystonia, of which pain is one of the more common non-motor features. Our ability to classify dystonia is also quite confusing. And so the first sort of classification schemes came back out in the 1970s, and we talked about this idea of primary dystonias, where that's the only thing you had, versus secondary dystonias, where your dystonia was because of a big head injury or you had lots of other neurologic problems for other things. And then this whole other category called psychological causes of dystonia. There was a big attempt by the International Movement Disorder Society that finally was published in 2013 to try to come up with better ways so that everyone's talking the same language in terms of the classification and the phenomenology. And this is where we shifted from using the term primary dystonias to things like isolated dystonias. Now, they really are the same thing, meaning that, you know, people really just have dystonia as their neurologic problem versus other things that go along with it. The other thing they did was they also tried to expand about what is the definition? What is the, when we use the term dystonia, what do we mean? And so in a lot of people's minds, dystonia is this idea of a very sustained, fixed problem. But for all of, or many of you, and certainly for movement disorder neurologists, we recognize that it's also just this intermittent movement. And when I'm teaching medical students and residents, I tell them, you know, look for a movement that looks very repetitive. So if somebody doing the same thing over and over again, that probably represents it being, or means that it's dystonia. In addition, to the abnormal posturing, there's also often a shaky or tremulous component to the tremor. And I think that was a nice addition to this definition. And because, again, doctors can now, I think, more appreciate it because of this shaking component is so common. We know that dystonia is often worsened when you do certain positions, or certain things. So the voluntary actions can bring on dystonia. And this idea of overflow, if you keep doing the movement, it can make it worse. And so you can get this advancing sort of overflow as more and more muscles can become involved. For many of you, you know about sensory tricks, and when I'm teaching medical students and residents about dystonia, I really try to get them to focus and try to bring out these sensory tricks. So this idea, if your head's turning, you touch it and it comes back, or your eyes are blinking too much, you touch it and they settle down. And you'll still see in the literature this idea that we try to divide dystonias into focal, meaning just one place. It's just your neck, it's just your eyes, or it's a couple of places, eyes, mouth, and neck, or it's half your body, or it's generalized. And generalized dystonias are quite rare. And the literature on pain in generalized dystonia is almost non-existent. So there's very little literature about pain and people with generalized dystonia. And so most of the literature relates to focal dystonias. And so I'll go through some of the evidence for that. But if you look at, where are we with our understanding of dystonia, it's still very incomplete. And so we know, and I think all of you know, that there are certain genes that clearly cause dystonia, and there are many of them and a growing list of them, and they've certainly helped us understand dystonias better. We know that there can be, for some people, an environmental influence. And I think the classic example of that is the whole musician's dystonia. And so this idea that overuse of doing a very specific task over and over in the 10,000 hours to be a professional musician can overdrive your system, and that can lead to dystonias. This whole concept of, well, is there something else? Is there some susceptibility factors that somebody might have that might generate their predisposition to develop dystonia? And those are things that we think may be there, but we really don't know enough about them. Once you've triggered this process, we know that the dystonia really has a real problem within many different cell groups now in the brain. So basal ganglia, these are groups of cells deep in the brain, and their job is to help modulate movement. The cerebellum, it's felt to be the balance center of the brain, but also is important for coordination, and increasing evidence shows that that plays a role. SMA is supplementary motor areas. So these are areas in the front part of your brain that help sort of the pre-programming and the pre-setup to make a movement. And then we have our primary sensory cortexes that receives all the information from our bodies, and the motor cortex that then sends out that signal to say, okay, move your arm. And we know that what's happening in people with dystonia is that there's, at the basis of it, is there's this idea of an impaired inhibition. So that you're not focusing this information in a proper way, and you're getting kind of spillover into other movements. And so this is felt to be part of this abnormal plasticity. So the normal malleability of your brain is there's something that's happened. And also there's increasing evidence that there's a problem with the information the brain's receiving. So the sensory information that's going into this whole process. And all of these come together and generate an abnormal movement, as well as abnormal sensations like pain in dystonia. So maybe taking another step backwards, well, pain is not pleasant. So why the heck should we have, why we evolved to have pain? And it turns out that, so what is pain? It really is just this idea that it's an unpleasantness. And it's that inherent unpleasantness really is what pain is about. And why do we need it? Well, it turns out that it's one of our oldest evolutionary senses, and it really enabled us to evolve to where we are, because if you didn't run away from the lion that was chewing on your leg, you were going to be in big trouble. Or the same thing, you reached out for something climbing a tree and you grabbed onto something sharp, and if you just kept climbing, you'd get yourself in trouble. So if you don't move away from the thing that's hurting you, you're not going to be able to pass on your genes. And you needed to be able to move quickly. So you had to have a system in your body that you would be able to react quickly to whatever else you were doing at the time, to focus your attention on whatever was causing that pain so you could get away from it. And so this is really why we evolved pain. And I think, you know, one of the most dramatic examples I see not uncommonly is, and I think for a lot of you have, you know, other family members or loved ones that, you know, if you have, you know, like people have bad diabetic ulcers, they don't realize that they can't feel their feet well, and they cut themselves and they get infections. And so it really is a very key process that we need to be functioning extremely well for us to survive. If you look a little bit in terms of, you know, how does this work? And so very simplistically, you have nociceptors. So these are pain receptors, and they're throughout your entire body, in your skin, in your muscles, in your tendons, in your arteries, in the covering of your brain. So we have these pain sensors everywhere. And these pain sensors send an impulse from wherever the pain originated from down into your spinal cord, where they make a connection in your spinal cord. And then that is a very actually complex with many different neurotransmitters involved. And then that signal then travels up into your brain, and it travels up into many different areas of your brain to relay this information. However, it's not, of course, that straightforward. And so this you have these pain receptors that send the signal to your brain, or sorry, to your spinal cord up to your brain. Your brain then needs to interpret that information. And there's a whole modulation of that information back down through the back part of your brain, your spinal cord. back down through the back part of your brain, your brainstem, into your spinal cord to send the information back out to the periphery. So again, trying to make a decision as to, how much do I need to react to the pain? Do I need to start running? Do I need to move my hand? And so there's a lot of integration of that information, but also there's a lot of modulation that happens. And so there's many different areas in your brain that have evolved to play an important modulatory aspect to pain. So both our emotional centers in our brain, the amygdala, our memory centers in our brain, that are important for remembering what caused the pain and how do you react to it quickly. But also then, is there ways to modulate this outflow information to control the pain so you're not constantly struggling with that? And so there's a whole balancing between receiving pain information and your brain sending information back out to modulate that response to that painful stimuli. And of course, things get more complicated. So I show this diagram because it looks really complicated, and the idea is pain really is very complicated. And we're only really just starting to put sort of the finer details of the pain process involved. And again, so this is a big, there's still many areas of the pain pathways that are getting worked out and different pain molecules that are getting worked out. And so this is something that still needs some more work in general with the pain specialists. If you look specifically at dystonia, that we know that cervical dystonia, so dystonia that involves your neck, is the most common group of patients that have pain associated with them. So on average, about 75% of patients who have cervical dystonia have pain associated with it. It's less with hand dystonias, and about the same in terms of when you look at the evidence for people who have dystonias in their lower limbs. So maybe about a third of people will have pain associated with it. People who have blepharospasm, so dystonia of their eyes, the component of real unpleasantness to it, there certainly can be irritation, but true pain with blepharospasm seems to be very low. And the one big review study that I found really didn't report pain in people who have oromandibular dystonia, although I know that's not true because I do have some patients who have oromandibular dystonia and definitely get pains around in their jaw. Spasmodic dysphonia or dystonia of your voice seems to be not associated with significant pain. So if you look at the most common focal dystonia with pain is cervical dystonia. And so what is the pain? So there's a broad variety of pain descriptors for cervical dystonia pain, whether it's an aching, whether it's tension, whether it's a sharp pain. And so there's many different descriptors for that pain. We know that the pain seems to be centered around the mid-neck for most people, and it can go up into the neck, the back part of the head, can go down into the shoulder area, and can be in the upper back. But I tell people that if they start getting pain that goes all the way down their arm or way down low in their back, that may not be from their dystonia and might be something else going on neurologically. The other thing that's important to recognize that people with cervical dystonia often have a lot of different types of headaches as well. And so up to 20% of people will suffer from chronic daily headaches of different kinds. Some of that is just tension headaches, some of that is true migraine headaches, and so it can vary a lot. And the location of those pains can be very highly variable. So it can be back of the head, it can be top of the head, side, and so that those types of pains can be all over the place. What causes dystonia pain specifically? And again, it's not clear. So, we know a lot of people with dystonia, they have this idea of really sustained muscle contractions. And so, for a lot of people, when you see the movement and it looks like it's painful. And so is there an idea that this sustained muscle contraction is actually causing some sort of damage to the receptors, damage to the muscles themselves? But that doesn't seem to be certainly the only thing, because we know that pain in dystonia is not just from the muscle itself, because some muscles that don't seem to be involved, and especially the mid-trapezius muscle for people with cervical dystonia, for a lot of people, that muscle doesn't feel particularly tense, yet it generates a lot of pain. And so there's not a one-to-one correlation with what's going on with the muscles that are more active seem to be also the ones that are more painful. And so this idea is there are other potential processes that are involved in the mechanisms of pain versus just a straight muscle problem. And there certainly is growing evidence that that's the case. And so these pain receptors, there may be something that's happening with those, but also the way that your brain is perceiving that pain. And there's increasing evidence from many different studies to suggest that is happening. So if we go back to our diagram, we know that people with dystonia, they can have definitely pain arising from the receptors not working properly. We know that the pain can also, there's a component that's now been measured in people with dystonia where the descending pain modulation and inhibition and controlling that pain, there's something that goes wrong with that. And there's increasing evidence that there is changes in how that pain is perceived within the brain. And again, the mechanisms of what goes wrong in terms of the brains of people with Parkinson's, this lack of inhibition, maybe there's some that those similar pathways are involved in the control of pain and this lack of normal inhibition that would then project and stop the pain from happening down in your neck or in your leg. Those processes themselves are being affected by the dystonia pathways that are going wrong in the brain. So with that background, where are we with treatment options for people with dystonia? So I think it's maybe important to take a step to realize that a lot of the traditional pain treatments are options for the pain. And so if we look at our mechanistic pathway, the idea of applying cold, some people is applying heat, using topical things, maybe that is modifying how these peripheral pain receptors are working and changing the signal. And so a lot of people with dystonia, those types of things can be helpful. We have lots of treatments. So the most common one that's being used is anti-epileptic. So this is gabapentin or the pregabalin or Lyrica. Those are medications that can help modulate this abnormal transmission of pain. Certain things like the traditional narcotics, so opioids, are things that can be used to help control pain. And I think everyone realizes that long-term use of those is not great. And so we do have to be careful if that is being considered. And I think most people are aware there's different types of blocks that the anesthetists can do. Usually, unfortunately, they're relatively short lasting. Some of these medications do work more within the brain, others work within the sort of descending pain pathways, but also people have been looking more and more, especially in the pain clinics, where people who have chronic pain, they try to give people the tools and techniques through this cognitive behavioral therapy to help manage the pain. And so hopefully your brain can adapt so that you're limiting what your final output of pain is. So if we then if we look at, what are the more specific dystonia treatments, there's not that much in the literature. So we know that botulinum toxins have very good evidence that they clearly can have an effect on decreasing pain. And so this is both for the botulinum toxins. Now there's 3 type A's now are available in Canada. Type B has been approved in Canada, but not marketed. And I think it's just not something that we're going to see marketed because it has lots of problems. But if you look at the studies that have been done for cervical dystonia, it turns out that of the symptoms of the shaking, of the pulling and turning, or of the pain, it seems that in those studies, it actually is the pain that improves the most versus the other features of their dystonia. The studies that have been done with focal limb dystonia is it's similar, where with the botulinum toxins, you seem to get the most benefit in the pain versus some of the other symptoms of the dystonia. The other treatment group is deep brain stimulation. So people who aren't responding well enough, that those who do eventually go for deep brain stimulation, and most common target for dystonia is the globus pallidus, so a deep structure in the basal ganglia. We know that those people tend to have a very significant improvement in their pain. Once you get past those two main treatment options, though, that if you look for evidence, there's really not great. And so the typical medications that we use to treat dystonia, so the anticholinergics, so these are like trihexyphenidyl or Artane, benztropine or cogentin. When you look at studies, does it specifically help pain? And the evidence is really not there. So typical benzodiazepines, so these are all the PAM medications, clonazepam, lorazepam. Those, again, we use those sometimes to try to help the dystonia, but there's not great evidence that it specifically addresses pain. And the other medication that gets tried is baclofen, but again, not great evidence that it specifically addresses the pain issue. More invasive things, there have been studies with intrathecal baclofen infusions, and if they do, create a very high block and give it up into the neck areas, that there is some evidence that that can help control people's pain. But again, not something we typically do very much of. And so why would botulinum toxin help with the pain? And so there's a bunch of different theories, but unfortunately the bottom line is we're not sure. There's this theory called what's called the ischemic muscle theory, meaning that your muscles are contracting very hard, and because they're contracting so hard, there's a lack of blood flow and oxygen to the muscles. And then when that happens, then your pain receptors kick in and they send a pain signal back to your brain that your muscle is not happy. But the trouble is that when you look at treating people who have, let's say, cervical dystonia, that are certainly people who you've injected and the pain improved, but it actually didn't improve the hyperactive muscle contraction. And so that would sort of cause troubles with your theory. And then the reverse happens where you've actually helped totally relax the muscle, but you're still getting pain from that muscle. And so if it was only the effect of what was happening with the contraction of the muscle, you would think that the pain would go away, and that's not true. So people have been looking at other types of theories. And so this gets back into what else could the botulinum toxin be doing at the neuromuscular junction other than relaxing muscle contractions. And so there is some evidence to suggest that locally, that not only might the botulinum toxin have an effect on contracting of muscles, but it might also have an effect on those specific pain receptors and blocking the usual chemicals that the pain receptors are releasing to help with control and modulation of pain. There has been some work over now more than 10 years that could botulinum toxin have some central effect on the brain. And really the bottom line is that that's really not really good evidence. There is some rat model data that suggests that maybe this higher central effects might be playing a role, but you have to imagine you have to get the toxin that's in the periphery travel down through the nerve, go across a nerve junction, back up into the brain to have an effect. And so they've been able to do this in some very, I would say, artificial mouse and rat models, but really the evidence that this could happen in people is really very lacking. And so I think for most of us, when you look at the mechanisms of pain, maybe some of it is related mechanism for botulinum toxin helping pain is maybe some of it is related to helping relax the muscle, but also this idea that we're having an effect at the neuromuscular junction on the pain receptors themselves. So it's changing some of the inflammatory responses and maybe some of these, chemicals that modulate pain at where the toxin is being injected. And again, this idea that maybe some of these effects might travel back into the spinal cord, it's a big maybe, and even less is this idea that it gets up into the brain itself. So what else could you do to try to help pain with dystonia? So there's certainly a huge number of techniques that have been used to try to help people manage their dystonia. These are things, EMG or EMG biofeedback type things, different various forms of electrotherapy, TENS machines, different types of relaxation training, massage, stretching. And so there's lots of different things that have been tried, but unfortunately, really, when you look from an evidence-based medicine standpoint, have really not been proven very well. There have been a number of studies looking at what if you combine the use of botulinum toxin and physical therapy, and there have been a few reasonably done randomized studies that show that maybe for cervical dystonia, very specific regimens, some of them use sort of a 2-week therapy after you got your injection, some of them use an 8-week therapy, all of them relatively short-lived, not been shown over repeated injection cycles, that maybe there's a role for some physical therapy in terms of after you get your injections. There's less evidence for when we do the injections for hand dystonias. There's been a lot of interest now over more than 10 years with other sort of ways to change how your brain is functioning. And so probably the most common one is this transcranial magnetic stimulation. We have a very specific probe and it sends a magnetic signal through your skull, and we can use that in research to help try to understand how the brain's been working. And there's been some studies, but not very good ones, that suggest that maybe there can be a temporary benefit in pain using this transcranial magnetic stimulation technique, but unfortunately, it's still considered experimental. And for those studies that did show some benefit, typically the benefit is very short-lived. I mean, I think one of the things that's now certainly, very much talked about in all fields of medicine and society is cannabis. And so, how does that fit into our treatment of pain and dystonia? And so it turns out it's not actually a new concept. So David Marsden, he's the godfather of movement disorders, who was very prominent back in the 80s, 90s, and unfortunately died at a young age. But he described a single patient back in 1981 who smoked cannabis and said that his pain and his dystonia were significantly better. There was then a number of small case reports of a similar type of benefit. There was a study using CBD that came out in 1985, where they tried to use videos and try to show the people's dystonias, but independent review of the videos about using cannabis, the CBD, whether it was beneficial. And they said that there was up to a 50% improvement using CBD. The trouble is it was not a randomized study, and you can see it's only 5 patients. And so really not very good evidence. There was better studies that were done by Susan Fox, who now is a movement disorder neurologist in Toronto, using nabilone. So this is a synthetic THC product that she did in a very well-controlled study that unfortunately did not show benefit. Another type of synthetic oral THC product back a little bit more recently, 10 years ago now, showing also that unfortunately it didn't seem to improve pain. And so when you look at the evidence for cannabis specifically in dystonia, there really isn't very good evidence for it playing a role. That doesn't mean there's not been thousands of patients who have tried it, but our ability to show in a scientific way that it truly helps is unfortunately still not there. I think most people appreciate that it is, especially the THC component in cannabis, can have a lot of central effects. And so in these studies, they typically were mild, but it did have an effect for some people on their blood pressure. It certainly can cause dry mouth. And certainly the more THC that's in there, the more cognitive changes that you can have with that. Certainly for some people, they have some lightheadedness, the sedation component, and for some people, also difficulties with balance and being more unstable. So although I know commonly used, the evidence for its effect is still not great. And so in summary, our understanding of dystonia is improving, but far from complete. We know that our understanding of pain is getting better, but again, far from being complete. And there are, unfortunately, still limited number of specific treatments for pain in dystonia that have been proven to be effective. So I'll finish off with the video. Just it's something that I guess in our COVID days, none of us have been able to travel, so I thought I'd show a video of, I've been fortunate enough to be able to take my kids out skiing out west, and this is one of their favorite resorts. So this is Revelstoke, where you go up the chairlift, then you have to walk up this stair, and you come off the backside of the mountain with just unbelievably spectacular views. And it really does feel like you're on top of the world. And I think for a lot of us, we really wish we could get back to our traveling. But it is also one of the steepest hills I've ever been on. And so that is actually my daughter from a few years ago. And she, of course, being a fearless child, just charges into this steep drop off, and Dad kind of gingerly goes over the edge and tries to ski down with her. But you'll notice, if you watch carefully, the snow is falling faster than I am. And then, you know, being a dad and shooting the video, made the mistake of filming her coming down through this very steep hill that actually had more rocks than I thought. And then at the end of the day, showed my wife the video, which was a very bad thing to do because she certainly didn't condone this, this particular run. So thank you.
I love it. Thanks, Dr. Grimes. That was an excellent presentation, and really, I learned a lot about the way that we process pain and where pain comes from. So thank you very much for sharing. And throughout your presentation, there have been a number of questions that have been coming in. But before we get to those questions, I just wanted to quickly remind the group here about some of the additional patient tools and resources that are available on the Dystonia Canada website. So you'll see on screen here, there are a number of links to resources for self-care, recognizing that, we're really trying to empower patients at this time and, give you the tools that you can use to really help you live your best life. And then the other piece I just wanted to mention is that we do have on the resources for self-care webpage, includes information from a variety of sources, but in particular, which may be of interest to those of you who are tuning in today, includes details on the online workshops for chronic pain management organized by the South Lake Regional Health Center. So if you are interested in that, please feel free to check out those links. And, obviously we have listed here a number of resources, but if you would prefer, you can always come directly to DMRF Canada, and we're happy to assist you, either put you in touch with local support groups or direct you to the place on the website that would be relevant to you. So now with some time left, let's dig into some of the questions. As I mentioned, there's been a number that have come up. And so I will just dig in here. So one of the questions we received is from an individual who says that he has cervical dystonia. Over the counter pain medication no longer works. He thinks it may be age related and related specifically to arthritis. His doctor is recommending opioid type of medication. He's really not wanting to do this. Do you have any suggestions on this, Dr. Grimes?
Yeah, I mean, a common issue, and yeah, that certainly, I didn't get into that in terms of just because you have dystonia doesn't mean you can't have other sources of pain. And so, for some people, as I sort of briefly mentioned, this idea that, if you have pain that goes way down your arm, maybe it's a specific pinched nerve in your neck, but also people with especially cervical dystonia, there is more wear and tear changes from the movement of your neck. And so you are at higher risk of getting, wear and tear, osteoarthritic type changes in your neck, and that can be certainly another reason for the pain. I would agree. I mean, typically, and for most physicians now, we try to stay away from using narcotics to manage chronic pain. And so trying those other chronic pain medications like gabapentin or Lyrica before we get into the narcotics, because of the difficulty with those over term, and the side effects with narcotics is something we do try to avoid. But unfortunately, for some people, if we really can't manage enough with these other non-narcotic treatment options, we're stuck with not great treatment of narcotics. So certainly other things to try first would be, certainly Tylenol and in bigger doses is safer, but still something you need to watch out for.
Okay, thank you. I know that you mentioned a listing of a number of alternative pain management options. There's a question here that's specifically around neurological music therapy. So the question is, have you found any articles or studies pertaining to neurological music therapy? And obviously this would be a complementary to, existing treatment.
I think I'm not seeing anything specific related to the pain component of music therapies. People have tried to use music therapies in different areas in neurology with the idea of, I think, in terms of trying to see if that could help reset some of these abnormal pathways and try to build on this plasticity trouble with the brain. But I'm not aware that there's any good evidence that those types of therapies have been proven to work. I know some people try them and they feel like they work, but we do have to be careful of that kind of data to say that it's evidence that it's clearly effective for everyone.
Okay, thank you. The questions are pouring in. We have another question that is specifically around cervical dystonia, and this individual is interested in learning more about the physical therapy you would recommend to follow botulinum toxin injections, if anything. And I should mention that this is an area that DMRF Canada does plan to explore more, but we'd love your thoughts on if there's a specific type of physical therapy that you would recommend.
For me, I typically just recommend that people do straightforward stretching exercises. I'm always a little bit concerned about, because dystonia can be driven by using the muscle that has the dystonia, the more you use it, the more it potentially can exacerbate your dystonia. So I usually just recommend sort of stretching exercises, your neck in all the different directions. And if you can do that at least a few times a day. Again, I'm a little bit cautious about more specific neck exercises in themselves. And when you look through the studies that were done, again, there was a wide range of different protocols that people have used in those studies. And again, they're a little bit all over the map. But again, I think in general, the stretching ones are the ones that I typically get people to do.
Okay, thank you. We did have another question specifically around yoga. Any thoughts on yoga for reduction of pain?
Yeah, I mean, yoga in itself is excellent. It does work on strength. It does work on stretching and range of motion. So I think that is very good. I do caution people about, for some people with especially cervical dystonia, a lot of upper body type things can sometimes exacerbate the dystonia. So you have to be a little bit careful. But yoga typically is more, arms down and stretching out and things. And so I think that's a very reasonable thing.
Okay, thank you. And just for those of you who are interested in investigating yoga, we do actually have some videos on our website that we're generously funded by our support groups in Edmonton. So it's called Yogatonia, and it's light yoga that's specifically sort of taking into consideration the population that we're thinking of here. So. There was a question that came in earlier when we did registration that I just want to put forward here. The question is around how you differentiate muscle pain from nerve pain. And the question is, can muscle pain be distinguished from nerve pain in cervical dystonia? Would it be common for both to occur on the same side? This individual says most pain is felt in the neck, but it can spread down to the other side.
Yeah, and so there is definitely some overlap in terms of, and again, I sort of went over that briefly in terms of, people use different descriptors of their dystonia pain. But the more the pain is like a sharp, especially shooting pain that goes, especially if it goes down the arm, that's when I do get worried that it's a nerve pinch issue. And people with cervical dystonia, I think, part because of that sort of wear and tear change, they are more at risk for getting definite, exiting nerve root pinches. And so the more you have a sharp pain that shoots down your arm, the more I get nervous that maybe it is a very specific quote, radiculopathy is the medical term for that. And so that is different than the dystonia classic tension type pains, but there's definitely a gray between those descriptors. And again, we wind up often treating, and when you look through the literature, the sort of the nerve pain definition can vary quite a bit. And so we do wind up trying, even if we think it is mostly centered within the muscles versus centered in the nerves, we do still try those nerve type medications like the gabapentin or Lyrica pregabalin.
Okay, thank you. So we have a comment just to sort of validate your point around DBS as a potential treatment for pain. There's an individual here who's just sharing her experience, which is that she had DBS in 2005, and that resulted in 75% improvement in both pain and tremors. So obviously that's one person, but just sharing. Somebody is asking, I don't distinguish between pain and my daily headaches. Are headaches different, and should they be treated differently? And I know in your presentation you spoke about that, but I'm wondering if you can maybe elaborate a little bit more.
Yeah, I think that it maybe opens up a little bit more options in terms of, what is the mechanism for people who have cervical dystonia and pains in their head. And so sometimes, if it does have a migrainous throbbing type quality to it, then we do get into kind of migraine treatments and try those things. I certainly have had quite a few of my patients now with cervical dystonia who have different types of headaches try botulinum toxin injections for headache. And so the sort of the chronic migraine protocol of botulinum toxin. So that is an option for some people. And so, yes, if you have concomitant head pain, we sometimes do go down the treatment of sort of the typical headache treatment options, not just sort of cervical dystonia pain options. And there often is overlap. So people, I certainly have people who, they get headaches. I do their neck injections, and their headaches go away for 2 months, and then as the injections wear off, their headaches come back again. And so there is definitely a correlation for some people with their injection cycles and their headaches.
Interesting. Okay, thank you. We only have time for a few more questions, and I know there's a lot here. This person says, I have OMD and sometimes I have pain in my face and jaw. Could this be due to nerve irritation from clenching? And if so, is there some treatment for this?
Yeah, so I sort of mentioned briefly in the study that I was a bit surprised when you look through the literature about this, there's no pain in oral mandibular dystonia, but clearly that I don't believe that. And so for some people, yes, definitely the jaw clenching, and I do sometimes inject botulinum toxin to try to help relax the jaw muscles with the hope that it is going to also help with the pain component of that. So that I think would be one of the options is to try to relax the jaw muscles so that it can help the pain in addition. And so that would be one of the more specific treatments I would try, other than sort of usual other sort of jaw pain things for some people, having not a bite plate, but I'm blanking on the term, a mouth guard. So having a mouth guard in to help, especially if they're at night, if they're clenching more. So sort of along the lines of when we treat bruxism or just teeth clenching at night.
Okay. I know that you had mentioned for one of the earlier questions, the use of Tylenol as an over-the-counter medication. There's just a question here that's saying, other than botulinum toxin, would you recommend anything else over the counter? And I'm just giving you the chance to add anything to that if you wanted to do so.
I mean, we're always, certainly Tylenol is the safest. Anti-inflammatories, naproxen, all of those types of medications, ibuprofen, they can help mild to moderate pain, but again, I'm always a little bit nervous because of the long-term issues with anti-inflammatories and causing stomach ulcers and things like that. And so intermittent use is probably okay, but longer-term use, you do have to be a little bit worried about the long-term side effects of those types of things.
Got it. Okay. I'll do one more question here, which is, I'm experiencing sharp spasmodic pain shooting from my neck to head. Could this be caused by arthritic changes in the neck?
Yeah, I think we went through that a little bit before, and yeah, definitely it can, and so that there can be an overlap of pain from arthritis in your neck and pain from the dystonia itself, and those two things can go together. Unfortunately, often there's not a lot of great options for the osteoarthritis pain in the neck, and so we wind up kind of trying all the same things anyways, but those two types of pains can definitely occur together.
And for obviously for all of these individuals, you know, we would encourage them to have conversations with their doctors, and I guess it's just a question of making sure that they're communicating, you know, what their pain is and what parts of the body are being affected, hopefully to help their doctor give them, you know, the best advice.
Yeah, and unfortunately, as you can see, the evidence for treating pain in dystonia is not that much different than treating pain in general. And so for, you know, this is a common thing that most, you know, family doctors or internists are treat. And so, you know, you're probably going down the same pathways, you know, with a neurologist as well as with your family doctor, because of that lack of evidence for sort of dystonia specific type treatments.
Perfect. Okay. Well, I'd like to thank you so much, Dr. Grimes, for taking the time to answer these questions, and thank you so much to the community for taking the time to listen to the presentation, and obviously for sharing your concerns and experiences. We just have 1 minute left before we close, and so I'll just quickly turn things over to Archana.
Thanks, Stephanie. And thank you very much, Dr. Grimes, for that very informative presentation. I just wanted to quickly remind everyone, I know we already mentioned this earlier, that DMR Canada is not recommending any specific course of treatment for dystonia. Any newer experimental treatment mentioned today may be still relatively new or exploratory at this time. Please speak with your movement disorder specialist about any course of treatment to ensure that it is right for you. We do have a closing survey at the end as you end the webinar. Please do take that survey to let us know what supports you found useful or what supports you'd like to see during this time. And also please leave your comments and thoughts about the webinar today. And finally, I want to take a moment to thank Allergan and Abbvie Company for their very generous support of this webinar series. And a reminder to everyone that a recording of this webinar will be available online, and it will be available on the website that you see there, dystoniacanada.org/COVID-19 impact. And I'd like to thank you all again for joining us today. And thank you very much again, Dr. Grimes, for your time today.
Okay. Thank you.
Thanks, everyone.
Thanks, everyone.
Bye.
Bye-bye.